Yesterday, Governor Jerry Brown signed controversial legislation allowing physicians to prescribe lethal doses of drugs to terminally ill patients who want to end their lives. Dr. Richard Chaffoo joins us now with more on this new law. It's called the End of Life Option Act. Doctor, good morning. Thanks for being with us.
Good morning, Raoul.
Okay, first off, let's start with who will use this law. Explain that to us if you could.
So the law, and it's still being rolled out, essentially will be for people that are thought to be terminally ill. It will require two physicians to make a determination, and then obviously the patient would request treatment within 6 months. If the patient is supposed to be dead within 6 months, and that would be the point at which they would be allowed to do what's called physician-assisted suicide.
And we reported that it would need two doctors' approval, and the person would obviously need to be of sound mind to make this decision.
Correct.
Let's talk about the process for someone who wants to die. What does it entail from beginning, I guess?
Well, it's still not clear, Raoul, and the problem with this type of law or legislation is that we don't have a lot of details about this. We know that, the end of life varies, and obviously it's going to be, I think, very difficult for a physician, if not impossible for a physician, to determine exactly how long a patient has to live.
What will be the checks in place? You said it's still early on, obviously, but what kind of checks are in this new law to make sure that the right decisions, the good decisions, are made?
Well, Raoul, that's really a good point, and we don't know what checks or balances are in place, in fact, even if there are any in place. We've seen similar legislation passing in contiguous states, Oregon and Washington, and unfortunately, what's happened in those states, Raoul, is that those that are under Medicare or Medicaid or uninsured, this law has actually prevented people from getting their proper health care because the insurance would step in and say, you're at your quote terminal phase, we're going to offer you physician-assisted suicide, but we're not going to necessarily offer or recommend treatment that even the doctor would recommend for that patient in that situation. So it does really speak to the heart of the issue.
Wow.
And gets in between the doctor and the patient relationship and actually makes a financial incentive or a decision that really doesn't need to be there.
Okay, let's delve into that a little bit more. Kind of rehash it. Some say the bill would invite the insurance companies, as you said, to take advantage perhaps of the poorer patient. They would have to pay for these life-ending drugs. So how would you see this kind of, not skirting the law, but how would that come to be? Would it be that it's almost an elective procedure where the insurance wouldn't cover something like this even though it was legal?
Yes, and we've seen that in these other states, as I've said. Unfortunately, no one can really predict when a patient is going to die.
Sure.
And the final decision needs to be made between that patient and the physician. And the problem is that in these contiguous states, that well over 2/3 of those that ended up electing physician-assisted suicide were either those that were uninsured, obviously very poor, or those that had government-based insurance. And in fact, the government-based insurance stepped in and said, we're just going to offer physician-assisted suicide because it's less expensive than treatment even that their physician might recommend. So it's a very disturbing precedent that's been set.
Yeah, I was going to say that when finances and money come to play so much in these decisions, it's amazing. The financial cost of fighting the disease will become a fact. I can't fathom that, how that can be the case, but it's unreal to me.
It is, and also, a lot of organizations nationally and internationally have weighed in on this situation. Yeah. The American Medical Association, the World Health Organization, and the American Association of Patients with Disabilities have all strongly opposed this legislation because it really does corrupt the doctor-patient relationship. The Hippocratic Oath is the big issue at hand, at the center of this debate. We as physicians still in many medical schools throughout the United States and the world still take a portion or a variation of the Hippocratic Oath, which in its essence says, first, do no harm. So we're there essentially as the patient advocate trying to provide care. And end-of-life care can obviously be very trying both for the patient, their family, and the physician. But what we want to do is relieve suffering, provide the best care possible in an ethical environment that should not be dictated by a governmental agency, should not be dictated by cost or finances.
Relieve suffering versus you say do no harm. How do you have that debate with the oath in terms of some doctors? Some doctors are going to be against this and they won't prescribe the medicine.
I think most physicians will have a hard time with this because it goes to the core of the medical system. And most physicians, I think, will have a difficult time. You know, we can't play God. We can't know
Sure.
when a patient's going to die. We're there really to provide care, which is complex, especially at the end of life. And our job is really to be there to support the patient and the family, and not to support the insurance companies, not to support the government, but to be there as the patient's advocate to relieve suffering and to help in this very difficult time for the patient and their family.
You know, we were just talking about, I was quite frankly shocked that California, that there were 5 other states and not California that had laws like this on the book. I wasn't aware of this, so I was surprised and taken aback by that. Do you think this is something that the rest of the country and other states are going to follow suit with?
You know, Raoul, it does certainly seem to be a trend, but I think the public needs to be educated and to be aware that in those countries where there is strong government intervention in healthcare, there certainly is rationing of care. And while now we're trying to make a decision, or I should say the government's making a decision about who will live and who will die, in many countries around the world where the healthcare system is run by the government, they will decide who gets what kind of care and when. So for example, in many countries in Europe, if you're over 50 and your doctor feels that you would be a candidate for renal dialysis, guess what? You're not going to get it.
Wow.
Because you're on a list of, you're just too old to have it. So
wow.
It does speak at the core of the value of humans and the physician and patient relationship and how that's being corroded.
You know, I can't help but think with all of this news about Dr. Kevorkian 20 years ago was kind of spearheading this effort. Is this kind of what Dr. Kevorkian had in mind 20, 30 years ago?
I think so, and certainly there was a lot of pushback from organized medicine. There was a lot of, you know, unnecessary, you know, publicity and grandstanding.
Right.
And the issue at hand is that all of us that are involved with terminally ill patients take it very seriously, our oath, trying to reduce suffering. There are many medications, there are many wonderful treatments that we can help patients during this very difficult time. For example, Raoul, in hospitals, if a patient's admitted to a hospital, these can be family meetings. There are groups of people that will help a family and a patient come together to help make decisions, very difficult decisions about end-of-life care, but in the very end, the patient is at the center of this, and that's, I think, the problem is that discussion has been moved away from where it needs to be, which is patient-centered.
It's not an easy conversation. It's not an easy time, and unless you've been through it, you really don't know. Dr. Chaffoo, we thank you this morning for your expertise.